Thanks for coming this morning. Today I'm going to talk about active surveillance for prostate cancer. Over the past 1 to 2 years, there's been clinical phase 3 data with the PIVOT trial and also the REDEEM trial talking about outcomes in active surveillance. And also there's been lots of registered active surveillance protocols that have released this data that give insight into selecting people who possibly have clinically insignificant disease and how to monitor these patients on an active surveillance protocol. I'd like to start with the case. This is a 65-year-old, otherwise healthy male.
Did you have a beard then, Mike?
He's not bad on the slopes. PSA 7, clinical T2A disease with Gleason score 6. He's got minimal volume. He's got good voiding function, good erectile function. His otherwise history is otherwise benign. Just a quick question, looking at this gentleman, who all would consider this man a candidate for radical prostatectomy, radiation, or active surveillance?
Is he sexually active?
Yes, he is.
Okay.
He's married.
That means nothing. How old did you say you were?
So you're eating sexually.
Lucky
I'm
guy.
concerned about active surveillance with palpable disease. Remember, that's a biopsy sampling. So my thinking is that's T2. There's probably more there than 2 millimeter cores. Depends
Yeah.
on the depth of the tumors.
Exactly.
The radiologist.
Exactly, and that was only a 6-core biopsy, so I'll get there in a second, but he did undergo a repeat biopsy, which 12-core biopsy, and there is a chance of having a more invasive disease, but his disease remains small. So this gentleman, they chose active surveillance.
Did you do your combined biopsy that your brother talked about 2 weeks ago?
The MRI fusion, would I, as a repeat?
This man, it sounds like a pretty good one.
Yeah. It would be good. It would be good. Good measure. I would start with probably 12-core biopsy and see where that led you, and that's what they did. And then if you progressed, that's a possibility. So he was chosen active surveillance. This is a look at his data a little bit more closely. So he presented with PSA 7, the 6-core biopsy. His immediate repeat biopsy was 12 cores. This again showed minimal disease. He was monitored for a year and a half. His PSA dropped. He was not given a 5-alpha reductase inhibitor. And his repeat surveillance biopsy, 10 cores, was demonstrated grade progression to Gleason 7. So for another 6 months he was watched. His PSA jumped, and that was triggered for prostatectomy. And yeah, he did in fact have more aggressive disease on radical prostate pathology with Gleason 8. He did have localized disease and had good pathological outcome. So I'd like to talk about active surveillance. I think this brings up a couple of points. One, I want to look at the acceptance of active surveillance so far, radical prostatectomy rates, and how many people are choosing active surveillance. I'd like to review our ability to select appropriate patients for active surveillance protocols, that being those with patients with what is thought to be clinically insignificant disease. I'd like to review our surveillance protocols and markers for progression on active surveillance, as well as some of the active surveillance, the safety of patients on active surveillance through phase 3 trials, such as the PIVOT trial, which is an observation trial, and the other larger registration trials. And then also quickly review the benefit of secondary chemoprevention, 5-alpha reductase inhibitors on active surveillance. When I think of active surveillance, I think of this guy here. This is a good buddy of mine, Josh Duick. He's a fellow who, unfortunately, I was with him skiing when he had an accident in 2002 that made him paraplegic. This is him 10 years later, being the first guy ever to complete a backflip on a sled ski. So this is a very trick that put him in a wheelchair. I was talking to him the other week and telling him what I do, and he asked me, well, what is prostate cancer? What's my chance of dying of prostate cancer? Kind of looked at him in the eyes and said, none. If he keeps this up, there's no way he's dying of prostate cancer. So what is active surveillance? It's not the active surveillance done in the pre-PSA era where you're waiting for symptom disease. It's not watchful waiting where these patients aren't candidates for radical therapy. It's an active decision between the physician and the patient to decide to monitor the disease, evaluate its progression, and provide curative treatment if progression is demonstrated. When deciding for active surveillance, it's important to consider both patient and prostate cancer specific factors. So patient factors, their longevity. Unfortunately, we do have poor predictors of longevity, as well as their views on quality of life and treatment. And lastly, what the course of the prostate cancer is going to provide. Trying to stratify patients for prostate cancer. A large series, the Albertson series, demonstrates here that we do have an ability to stratify patients. If you look at our patient, 65-year-old gentleman with CT2A disease, you notice that there's no element of the dark gray box, which is their prostate cancer-related mortality over 10 years. So his chance of dying of disease is over 10 years is limited. Is there any purpose to treating this disease? This problem is going to be becoming increasingly prevalent over the past 10 years and will continue to rise if screening continues to exist. This is data from the BC Cancer Agency showing that the amount of people presenting with clinically localized disease, T2, T1 disease, is increasing and those with locally advanced disease is decreasing. I'd like to thank Dr. Kim Chi for providing these slides. This is similar with those patients presenting with node positive or metastatic positive disease. Note the PSA testing begun in the 1991 era did show a decrease in this in the people presenting with advanced disease.
Mike, those are relative numbers. Are you sure it's not just more people presenting with localized and the same number with advanced?
It's possible. It is relative,
This percentage on the y-axis, what is that?
Proportion.
Proportion of patients presenting to the BC Cancer Agency with node positive or M positive disease.
So 14% in 1998.
It's not more, it's a higher proportion. Or lower proportion.
Lower proportion.
It's going down.
It's going down.
Yeah.
So they're getting more and more
So
people.
in 88, it was 14% presented with advanced disease?
Yeah. And now we're seeing down to 4%. So it doesn't have the absolute number, but of the patients that we're seeing.
Can we see the previous slide? Requested proposals.
Yeah, no, that's good. So 80% people presenting with clinical localized disease in 2000. Compare that to 45% in 1988. So this is relative numbers. This data does correlate with the ERSPC data recently released. In their most recent update, they in New England Journal recently, they do show that there's increased mortality benefit to the screening group. I don't want to turn this into a screening talk. I do just want to make a point that certain groups, such as the U.S. Preventative Services Task Force, have said that screening may not be in the best interest of patients because the number needed to treat is too high. Their most recent reported numbers here, 37. They want to spare as many. They say that there are too many people are being presented with treatment-related morbidity and mortality, and as a result of this, screening may not be in their best interest. So I don't think the right target to this approach, if there is a benefit to screening, is to necessarily cut screening out. I think that we need to better delineate who we will operate on. In the United States, we're finding that more people are choosing active surveillance. This is prevalence, so numbers increase over time. It's not exactly the incidence, but we are finding more and more people are selecting active surveillance as a method of managing their low-risk prostate cancer.
Alan, how many people do you think here are on active surveillance at BGH?
Of the low-risk patients?
Well, this is Sloan Kettering has 140 patients on active surveillance. Do you have a sense of how many we're following?
I would say, well, percentage-wise of our low-risk patients, greater than 80% on active surveillance. But in terms of numbers, we're part of the Canary registration trial. In total, we have almost 300.
300?
Yeah.
So Sloan Kettering has fewer patients on active surveillance than we did.
Yeah, and I think this is again are the absolute numbers, not the percentages. I'm certain that this is just a small portion of the actual numbers, but it is increasing in the States slowly.
Andrew, it's a referral center, so they're sent patients for surgery.
And then
So they may see a skewed population of non-low risk patients.
That's a good point. So this brings up the issue that the discussion of longevity versus quality of life. It is a fine balance for patients to decide element of control over their prostate cancer, as well as balance their fears of the progression with fears of the actual therapies.
Is this another one of your friends?
I don't know this
What
guy.
happened to him?
He progressed. So there are studies out there looking at just how many people are selecting active surveillance. Some are on the order of 8 to 10% in centers across the United States are choosing active surveillance. From the CAPTURE database, which is demonstrated here, about 8.5% of people with the lowest risk criteria for prostate cancer are choosing active surveillance. So this is a CAPRA score. This is essentially the D'Amico low risk classification with other factors such as number of positive biopsies and patient age, 10 being highest risk. They label it here as watchful waiting. This is Dr. Cooperberg. When he described the data, he did say that the low risk people were on active surveillance. So they tried to assess why people were choosing active surveillance. I think important question is if you look at the surgery group, over 60% of the people choosing surgery are stating so because they enjoy the physical removal of the cancer, the ease of mind. Those people choosing active surveillance, a lot of them people don't know why they're choosing it. Some other people just didn't want invasive or active treatment. It was more convenient and they were scared of the side effects of surgery or radiation therapy. Active surveillance, it's increasing. It's becoming more and more important. There are many barriers to ensuring safety of active surveillance. We still don't have 100% ability to predict clinically insignificant disease. This in itself is the idea behind active surveillance. If we knew right away, we could tell people to go away and not come back and not worry about it. As well, there's a lack of defined optimal monitoring for patients on active surveillance and defined marker of when they've hit progression and when they require therapy. Dr. McLaughlin?
What about age? I don't say it's fine to say the age of people choosing active surveillance.
Versus watchful waiting or versus... yeah, it does come in as a risk factor for, so they have done studies where they look at, how many people of a certain age group, and age is kind of consistently one of the biggest predictors of people who choose active surveillance.
But how about a doctor asking a 75-year-old versus a 55-year-old? I mean, does age of the patient come into the decision making? I don't see anything that says a 55-year-old will be told this, a 75-year-old will be told that.
Yeah, absolutely. So if you look at inclusion criteria, most people are choosing 65 for active surveillance protocol. Anything younger, I think we should have a good look because only 10-year outcome data really are begin to be demonstrated. But that's a good point.
So Mike, I think a lot of people some people, including us, are doing surveillance on younger patients.
Okay.
Right? If they're very low risk, if they're sort of the indolent, according to Epstein's criteria, the lowest risk,
yeah.
It's very few patients that are 50. Now, the older the patient, the more you can tolerate. So, a 70-year-old you might tolerate a little bit, at least a 7, which you never tolerate.
Yeah.
50-year-old.
And I think that comes out also in the CAPRA criteria. I like that classification because it does take that into account. But yeah, it's a big factor.
Mike, could you give us a definition of the active surveillance when other biopsies indicated a portion of the rise in PSA, or is it just automatically at 1 year?
I'll get to that. That's the section that I want to talk about right now. I'll talk about our ability to predict, and then I'm going to talk about our monitoring on prostate cancer. This guy is a buddy of mine, sitting on the end there. So, risk stratification, PSA, Gleason grade, clinical stage, volume disease is important. Also, we're beginning to study PCA3 and MRI. If you look at the active surveillance protocols from across North America, Canada, United States, most people have a pretty homogeneous inclusion criteria, clinical stage T1C, some people are using T2A. Even BCCANT's agency describes less than T2B. Gleason score 6 and PSA less than 10, or look at PSA density. Here's the Canary protocol. It's left broad because it's an active registration protocol looking for biomarkers. They intentionally left the inclusion criteria wide. UBC does provide to this data set. Here I want to talk about PSA and its ability to predict insignificant prostate cancer. There are many difficulties with PSA, especially PSA at onset of diagnosis. But I do feel there is good data demonstrating that PSA elevated at the time of diagnosis is a risk factor for prediction of clinically significant disease, whether it's at 50, as described by Scardino, or PSA at baseline, greater than 10 being a significant predictor to progress of those patients on active surveillance by the Toronto group. Johns Hopkins released data saying that PSA and PSA density at diagnosis are predictors of future interventions of patients on active surveillance. And I want to spend the most time on this PSA less than 10 being an independent predictor of no overall mortality of patients on observation. Here's the results from the PIVOT trial. This is 731 men randomized to observation versus radical prostatectomy. The mean age of 66.8 years. They followed these patients for a median of 10 years follow-up. They were able to demonstrate no difference in mortality between radical treatment and observation, both for PSA less than 10 and for D'Amico low-risk criteria. It's done by intention to treat analysis. There is about a 10% of patient crossover between those people on observation who received radical prostatectomy and people on radical prostatectomy who ended up going on active surveillance.
Mike, was it on prostatectomy or was it radiation?
Prostatectomy.
What about the Gleason score? Is that
part of It's part of the D'Amico low-risk criteria, so they included it. So this data hasn't been published yet, so we don't have access to the raw numbers. This was presented to ASCO 2011, so this is taken from their slides. So one of the critiques is it has not been under peer review at this point in time. There's other deficiencies with this data. One is it is only 10 years. At 10 years, we don't have any information of surrogate markers at this point in time. As well, we don't know who's begun to develop symptoms, metastases at this point, versus those who have not. But at this point in time, it is the best evidence we have. Clinical phase 3 trial stating that observation is safe in people with low risk criteria and low PSA. I'd like to spend a little bit of time on the role of biopsy enabled in our ability to predict prostate cancer progression. Mostly I just want to say that it is important for a 12-core rebiopsy. Chuck talked 2 weeks ago at length about the benefits and merits of a prostate biopsy as well as some of the drawbacks. We do know that if you look at prostate biopsy, then those patients who undergo radical prostatectomy, there's a 25% chance of risk of upgrading. A 12-core rebiopsy will demonstrate upgrading 17% of these people. But still not 100%, and these people still do need to be monitored. Other things such as PCA3 and MRI have tried to provide additive information to this. Looking at PCA3 as a marker for progression, there's no strong data in PCA3 over large cohorts or a prolonged amount of time, but it has been shown to have direct correlation with tumor volume, low-grade cancers, as well as surrogate markers at the time of radical prostatectomy. Looking at the ability for PCA3 to predict adverse pathology at time of prostatectomy, there's an inverse relationship between its score and its ability to predict clinically insignificant disease, as well as tumor volume. Role of MRI also comes into play in trying to predict those people who have significant disease versus those who don't. studies done out of here demonstrate that it does provide diagnostic accuracy and improvement in assessment of a disease volume. Looking at its ability to predict scores on radical prostatectomy, it's shown significant benefit. The active surveillance protocol group out of Europe, the PREIS group, found that it was able to predict more aggressive disease in 27% of their patients elected for active surveillance. And these people subsequently went on to undergo treatment as a result. As well, those people on active surveillance, or of 114 patients who had a lesion suggestive of malignancy on MRI and went on to undergo a second biopsy, demonstrated that they were no longer candidates for prostatectomy or for active surveillance. So in summary, of our ability to predict clinically insignificant disease, there are no eligibility criteria that has been identified for active surveillance. I think clinical D'Amico low-risk criteria is a good measure of that. We must take into account that it's a spectrum disease. It needs to be taken into account with the patient perspective, their life expectancy and longevity, and our ability to predict their future. PSA less than 10 and D'Amico low-risk criteria are reliable predictors at 10 years of mortality. And if biopsy is performed, confirmation biopsy is recommended. PCA3 and MRI are interesting in their role in the future for selecting patients for active surveillance, but right now there's no clear data. Next, I want to go into our actual surveillance protocols and our ability to monitor and predict progression. Right now, PSA, DRE, and rebiopsy are the main criteria for monitoring these patients on surveillance protocols. In looking at which ones are most beneficial, we can look at the amount of patients who are leaving active surveillance. This is a study that UBC did provide patients to. It's a multi-center trial from 4 institutions, including Sloan Kettering, where patients were defined as having PSA less than 10, clinically T1, T2A disease, Gleason less than 6, and minimal volume. They did have a repeat biopsy at diagnosis, and T0 was defined at the rebiopsy date. They were surveyed with DRE, PSA, biopsy every 1.5 to 2 years, or to 3 years. And some patients intermittently did get MRI, not all of them. Median follow-up for this cohort was small, 29 months, and of which 43 patients went on to undergo therapy. So the 2-year probability of being on active surveillance was 91%, and 5-year probability of 75%. They tried to identify predictors of discontinuing active surveillance. You see up on the top that PSA has almost very little significant value in the patients who remained on active surveillance, whereas looking down at the bottom, those people who had significant disease on their biopsy were more likely to progress. Now, the Toronto Active Surveillance Group relies heavily on PSA and PSA velocity, PSA doubling time less than 3 years, to help decide whether or not a patient should undergo therapy or not. In their group, they have 450 patients. They followed them for up to 6.8 years, which is long in the active surveillance cohorts. They do include patient less than 70, Gleason score 6, PSA less than 10, and Gleason greater than less than 7 for people over 70 years old. As well, they include PSA less than 15. PSA doubling time less than 3 years was a triggered intervention. They do have a fairly heterogeneous data set. 65% of the people had Gleason less than 7, PSA less than 10. If you look at the people that progressed out of this cohort, about 60% of the people at 10 years were spared therapy. 40% of the people did progress and require therapy. Their outcomes were quite good at 6.8 years, with a 97.2% 10-year cancer-specific survival and 68% 10-year overall survival. So the data does look good from this perspective. However, Dr. Klotz did go on to say that he did not believe PSA to be an adequate marker of progression. He felt that PSA doubling time less than 3 years did lead to unacceptably high treatment rates. Other groups have been using rebiopsy as their marker of progression. The Johns Hopkins groups does look almost rely explicitly on their rebiopsy. They're rebiopsying every year. They do not do an immediate confirmation biopsy at the time of diagnosis. But they use their Epstein very low risk criteria. They're probably the most stringent of the active surveillance groups in their entrance criteria. And they demonstrate a median intervention time of 2.2 years. Of the people that progress, about 45% of them because of Gleason score upgrading, and some because of increased volume in their cores. Here we look at their biopsy. How many people went on to undergo active or aggressive therapy? About only 40% people are remaining on active surveillance at the end of the cohort. The other 60% did undergo therapy. Their indications, when they look back at their data, demonstrate that PSA diagnosis, PSA density of diagnosis, and year of cancer diagnosis were the significant predictors of those who progressed. They looked into the value of PSA velocity and PSA doubling time on the biopsy specimens at the time of, this was radical prostatectomy specimens and biopsy specimens. They found that PSA velocity and PSA doubling time were not significant predictors. They also had PCA3 in their data set. They had 294 men who provided PCA3. They found that there was essentially no benefit to PCA3 in monitoring progression, although it showed ability to predict clinically significant versus insignificant disease and volume of disease at the time of diagnosis. You look at the right, there's no difference in values for those who progressed versus those who didn't. On the scatter plot there on the left-hand side, or your right, I guess, the red triangles are those people who progressed with Gleason 7 disease. The green triangles are those who progressed with just unfavorable pathology, whether that's by number of cores positive or percent of core involvement. And the circles are those people who didn't progress. And there's no trend that can be discerned there. MRI, on the other hand, may have a little bit more benefit in monitoring patients on active surveillance protocols. In this study here, looking at about 80 men enrolled in active surveillance, they were able to find that MRI was a significant predictor of repeat biopsy finding as well as time to radical prostatectomy treatment. So a summary of triggers for intervention. PSA doubling time, PSA kinetics may not be adequate to monitor progression. A rebiopsy is required. The timing of this biopsy is not yet defined. PCA3 has no role so far in monitoring patients in active surveillance protocols. It's going to be registration trials like the Canary trial that's going to provide more data with regards to this. And MRI may play a significant role in monitoring tumor progression and guiding surveillance biopsies in the future. I'd like to spend a little bit of time on outcomes on active surveillance. We're going to look at primary outcomes with regards to survival as well. Given the length of the disease and the limited time we've had on active surveillance so far, we need to look at surrogate markers, so pathology at the time of radical prostatectomy and biochemical free recurrence post radical prostatectomy are important. And lastly, and arguably most importantly, is quality of life of patients on active surveillance. We've looked at the PIVOT trial so far. I didn't present earlier their overall mortality. Here you do see no significant difference in overall mortality for the less than PSA less than 10 and the DeMeco low risk criteria. So it's important to remember this is an observation trial. This is not an active surveillance trial. And active surveillance may have improved survival over this. Dr. Klotz tries to demonstrate this in a recent paper in the New England Journal of Medicine. What he's done is he's taken the Scandanavian trial data, watchful waiting versus radical prostatectomy, and superimposed the active surveillance data. These are two different cohorts. There are two different inclusion criteria of the patient. But the point here is trying to make is that people who are being surveyed and undergoing therapy may have improved survival. you can see the difference in stratification when you compare the radical prostatectomy group to the patients on active surveillance, showing a benefit of overall survival. As well, this may bring up that the active surveillance group done here is a PSA screened group as opposed to the Scandanavian trial, which is not. Looking at pathological specimens at the time of radical prostatectomy of patients who progressed on active surveillance, there is a significant amount of people who did have a tumor upgrading. This is 38% of patients did have upgrading at the time of their pathology in radical prostatectomy. As well, there's very high people with extracapsular extension and seminal vesicle invasion. For example, Gleason 6 disease, extracapsular extension is on the order of 5%. Here, the lowest risk group is the Johns Hopkins group at 15%. Also looking at their biochemical free survival post-definitive therapy, we have 3- and 5-year data released so far. The most 3-year data is very good at over 91 to 100% of patients. Toronto group, which did have a significantly higher rate of positive margins at the time of biopsy, did have a 50% 5-year biochemical free surveillance. So these are surrogate markers. Looking at the relevance of these markers in the course of prostate cancer is important. From the pound data, we do know that post-radical prostatectomy, people with biochemical recurrence have a median survival of 8 years until they began to notice symptoms from their metastatic disease, and approximately 5-year survival post that. After radiation therapy, the numbers are relatively equivalent. One of the most commonly asked questions for patients on active surveillance is if there's anything the patients can do to gain some sense of empowerment or control over the disease when they're on the active surveillance protocol. Dutasteride has been most studied with regards to this. It's a 5-alpha reductase inhibitor. This is done in the setting post release of their data from the REDUCE trial, stating that there is an increase or a decrease in prostate cancer in patients on dutasteride, but there is a slight increase in risk and high rate of disease. Looking at 2 of the retrospective data, the data is mixed. So they did go on to do a randomized placebo-controlled trial, this REDEEM trial. These are patients who had low-risk criteria. They were randomized to placebo or dutasteride, 300 patients. They had a 10-core biopsy at initiation, and then at 1.5 and 3 years had re-biopsies. So widely across North America, and their results demonstrate that perhaps there's a decreased progression at 3 years. 38% progressed at 3 years versus 48%. There was no increase in incidence of Gleason 8 disease in those men on the dutasteride. Dutasteride did have some more side effects, most predominantly their ejaculation disorders, and there was no difference in anxiety levels of patients receiving the dutasteride versus the placebo. This is only 3-year data. We know that we need longer data in order to measure the effect on prostate cancer and prostate cancer progression. And I'm interested to see what this does in the future. And also, given that Health Canada has recently released the statement saying that they don't recommend it for the increased risk of high-grade disease, and patients are aware of this as well as their family physicians, there may be some resistance to using dutasteride in patients with diagnosed prostate cancer. Although active surveillance is not an aggressive therapy, there is morbidity associated with it. These patients undergo a vast amount of repeat biopsies and have increased risk of biopsy-related sepsis. As well, there's studies discussing increased risk of erectile dysfunction from prostate biopsy, although minimal. And patients who are on active surveillance protocols do have a significant amount of anxiety. This is also the increased risk of symptoms from disease progression from lower urinary tract symptoms. So people were asked, about 300 patients were asked, after their therapy, were they satisfied? About 80% of patients across the board state that they're satisfied from their therapy. If they were asked to do the same thing again, about 80% of the people again said yes, they'd elect the same therapy. And now this was done at 3 months, 1 year, and 2 years. This is not people who progress. This does not state does not take into consideration the overall outcome of their disease. Also, it doesn't have any way to stratify the patients who do have significant side effects for therapy, just how bothered they are. Patients develop fistulas, rebiopsies, significant gross urinary incontinence. There's no way to stratify that in this point. The Scandanavian trial did have an arm in it which it looked at health-related quality of life. This is 400 patients who were randomized radical prostatectomy versus watchful waiting. As well, they included men with the population control. They did their surveys at 3.5 and 13 years follow-up. As well, when considering this, also take into account that 90% of the people in the radical prostatectomy group were on androgen deprivation therapy, as opposed to 30% of those in watchful waiting. Final results show that physical symptoms were similar. However, radical prostatectomy had increased risk of physical symptoms in the longitudinal data. Here's the data of their overall quality of life at 4 and 12 years follow-up, or 3.7 and 13.4. The radical prostatectomy in the salmon and the watchful waiting in the blue. We do note that at 4 years they're about equivalent, and then at about 12 years follow-up, radical prostatectomy group does have a slightly higher increased quality of life. This was not significant. Looking at other domains and health-related quality of life, erectile dysfunction, incontinence, daytime voiding symptoms, weak stream, and nocturia, we do note that those people undergoing radical prostatectomy have more voiding dysfunction at the beginning, more erectile dysfunction, but in the long term, these two stabilize, and incontinence and voiding dysfunction does progress in the patients on the watchful waiting group. So in summary, looking at the outcomes of patients on active surveillance trials, there is good 10-year data for low-risk prostate cancer that are observed when compared to radical prostatectomy. There's a thought that active surveillance may have improved survival over observation trials. This has not been proven. There's an increased risk of high-risk pathology and biochemical recurrence at the time of urological prostatectomy, which should be discussed with patients on enrollment to active surveillance. There is a minimal but real morbidity associated with active surveillance through anxiety, erectile dysfunction, sepsis, and progression of disease. Health-related quality of life outcomes, whether patients undergo watchful waiting or active surveillance, and radical prostatectomy are both poor when associated with the general population, and these two are actually surprisingly similar. Long-term or short-term data favoring the radical prostatectomy group, long-term data perhaps or short-term favoring the active surveillance, long-term potentially promoting the radical prostatectomy group. So, in summary, active surveillance is a safe option for very low-risk prostate cancer. There is no proven active surveillance protocol. Active surveillance is a multifactorial approach, approaching patient values, comorbidities, life expectancy, as well as prostate cancer factors such as PSA, biopsy, PCA3, and possibly MRI, to decide the risks and merits of active surveillance. And clinical trials of risk stratification, tumor markers, and imaging in active surveillance will reveal significant amounts of information on the natural course of low-risk prostate cancer as these trials mature. Thanks to Dr. So and Dr. Chi for helping me out with the presentation. Any questions?